first hybrid fellow. And we start our session by welcoming Dr. Javed sir. Javed sir is President of Aahfra India 2025-26. I welcome you, Javed sir. Thank you for joining us. Javed sir will introduce MARC sir today.
Good evening, ladies and gentlemen. Good afternoon, Dr. Mark. I welcome you all for this fifth session of the webinar of Aahfra Escalep Hybrid Fellowship in Regional Anesthesia. Our guest speaker today is Dr. Professor Mark. He is the head of Department of Anesthesiology and professor at Leuven University. He is also editor-in-chief of Best Practices and Research, Clinical Anesthesiology, and deputy editor-in-chief of the European Journal of Anesthesiology. His primary
कुछ कर
clinical
रही हो
interest
आप? मैं देखा लैपटॉप में बस ऐसी है, कुछ करते हो
focuses
अभी?
on obstetric anesthesia and
क्या
anesthesia for
करूं?
children and adults with congenital heart diseases undergoing non-cardiac surgeries. Most of his current research focuses on obstetric anesthesia. He has given more than 525 invited lectures, has published over 320 articles, and more than 30 book chapters. His H-index at Scopus is 50. He is within the top of the most of the cited authors in the field in 2020. He is editor of 3 textbooks of obstetric anesthesia. He was president of Aahfra Society. He is a member of Executive Committee of Obstetric Anesthesia Association. He is prospect chair and chair of the Aahfra Educational Committee. I'll welcome Dr. Professor Mark VELDE. Good afternoon, sir.
Thank you very much. It is a pleasure to be invited to your sessions on regional anesthesia and to be able to give a talk here. I will share my screen, and I hope you see my PowerPoint presentation now. Could somebody confirm that it's okay? Thank
Yes,
you.
It's visible, sir.
Thank you. So I was asked to talk on the prospect recommendations, principles and methodology, and some examples, and I will be discussing those. I come from I was head of the department, but in our institution, we have to change after 10 years. I remained 12 years in position because of the COVID crisis, the COVID pandemic, but now I'm still responsible for the training of the residents in training. So I come from the Catholic University in Leuven. It's the oldest Catholic university in the world, and we celebrated our 600th birthday last year. As mentioned, I'm editor-in-chief of the European Journal and European Journal of Anesthesiology and Intensive Care. And I have had some support from some companies for lectures, consultancy, or research. So these are my conflicts of interest I want to declare. I want to give you first a short history on the Prospect Group. The Prospect Group is a group of surgeons and anesthesiologists who develop procedure-specific postoperative pain therapy recommendations. And you can find our recommendations and our methodology and everything on the Prospect Group on these 2 websites. We are part of ESRA. We started in 2002, and we became in 2014 an integral part of ESRA, but we work as a completely independent scientific working group, and we appoint our own members. So postoperative pain therapy recommendations, but that are procedure specific, and that is very important. So I'm the chair. We have several surgeons, and undoubtedly you know Hendrik Kelet, who is the founding father, the inventor, the mentor, the whatever of enhanced recovery after surgery. And he's still, despite reaching 80 years old, very active, still producing PhDs and research, and he's one of the most active and most respected members of our group. We also have a number of anesthetists, all with a significant CV in postoperative analgesia, regional analgesia, and they provide. And you see, three of these people have an Indian origin: Narendra Rawal, Dilip Lobo, and Girish Joshi, and they are all very active in producing these guidelines. And then we have some members from Ezra. Always the president of Ezra is member, and two Ezra appointed people, but also we decide whether they accept them or not. It's based on their CVs. We have made a lot of guidelines. You see on the left the guideline, the surgical intervention for which we have made a guideline. You can find all details of this guideline in our website. And the year you see is not the year in which we made the guideline, but is the year until when we searched the literature. So for instance, if you take the appendicectomy guideline, we searched the literature up until and including 2022. The guideline was then published in 2023, for instance. We publish in many journals. I've given a few examples to promote my own journal, the European Journal of Anesthesiology, but we also publish a lot in anesthesia and in surgical journals as well. These are the planned updates for last year and for this year. The C-section guideline is published, is accepted for publication and is currently probably already online or almost online. Laparoscopic sleeve gastrectomy is accepted. Open thoracotomy is going to be published. The open thoracotomy and the C-section are both published in anesthesia. So there is a lot, and hallux valgus update will come, etc. And we also produce critical papers to research on perioperative pain management. What are the flaws? What are the problems in various journals? So I want to briefly give you how we work and what is the methodology of Prospect. So everything we say, we give as a recommendation is truly evidence-based. This means we will not accept low quality evidence as evidence. We will discuss it, but it's not a major factor. The evidence needs to be procedure specific. If we give advice, there has to be research done specifically on an intervention and postoperative pain, and not on abdominal surgery, for instance. We still will take liver resection, for an instance, is different than abdominal surgery for us, at least. It's not only work, does the analgesic procedure work? For instance, you give dexamethasone, you have to have evidence that it produces analgesia, but if it would have a lot of side effects, we will balance these risks to the positive effects on pain. So sometimes an intervention might work, but we still would not recommend it. But we will mention then why. One issue that is very important, and we see that unfortunately in a lot of studies that's very badly done, if you use an intervention alone, not with basic analgesia, you might find different results than when you use basic analgesia. For instance, let's take cesarean section as an example. If you give a wound infiltration, but you don't give paracetamol and NSAIDs to these C-section patients, then you might see a positive effect of the wound infiltration, which might be gone if you give paracetamol and NSAIDs. So it's crucial that they have basic analgesia, and sometimes that's not present, and we encourage people to do that in future studies. We're not only looking at anesthetic interventions, but also at various surgical aspects. And we try maximal dissemination. I think somebody's microphone is on. We try to do maximal dissemination through open access publications, and we or Ezra pays for open access, or the journal itself opens it for open access. We have also translate in 8 different major languages the summary of the recommendations to make it easier for people to understand everything. We are completely scientific independent in the scientific output and the selection of prospect members. Again, I want to emphasize the importance of basic analgesia, paracetamol, and NSAIDs. That is something, if you do a study in the future, you should always include that in both your control group and your intervention group. But many don't do that, and therefore we can have problems. This is our initial, well, we have had some methodological papers, but this was the first real methodological paper which describing in detail our methodology, published in Anesthesia in 2019. And it's similar to what we do now, and I'm going to use this one as a basis. So we select a procedure, then we select a subgroup out of the 16 to 17 people involved in the prospect group. And we then ask 2 or 3 junior researchers to help us for this procedure. And the 3 or 4 prospect members that we select, one of them will be the subgroup lead. We define then in detail, together with the librarian of the university where we work in, the literature search. And once we've done that, we will then do the search of the literature, and usually we take the last 10 to 15 years, or if it's an update of a previous version of a procedure, we will start at the end date of the previous procedure. We then select randomized controlled trials and systematic reviews by the 2 juniors, and if they are in disagreement whether they can be included, the subgroup lead or a 3rd junior will decide. And there need to be pain scores in numerical form available. And it should be interventions aimed for post-op pain specific for the procedure. We make a Prisma flow chart. We excluded studies will be tabulated with reasons of exclusion. And then we will stratify the different interventions in pre, intra, and post-operative interventions. And we will then, in categorizing them in types of intervention, and then we will decide whether they're positive or negative studies. And we say that there is clinical evidence when there is at least 1 in an NRS score or 10 in a VAS score improvement in pain scores. So if an intervention works, it needs to be clinically relevant, and we define clinical relevance as 1 NRS point improvement in pain. We then evaluate the risks and the potential benefits, and then the subgroup makes a recommendation on all the various interventions. We recommend this, we don't recommend this, and you say why you don't recommend. Everything is then sent to the whole prospect group, and then we, at least 4 to 6 weeks before we meet formally face to face, and we go every intervention and we discuss it point per point, and then we vote. We have a Delphi consensus process, and if there is not uniformity in the recommendation, we will publish it in the paper that the whole group was not in agreement with this. And then finally, we have the final version of the recommendations, and we make our publication, and it's also published on the website. There are reasons not to recommend interventions due to lack of evidence that it has any positive effect on pain, due to limited procedure-specific evidence. For instance, there is only 1 positive RCT and no other studies published. Due to inconsistent procedure-specific evidence, you have positive and you have negative studies. Or if the net of sum is more than 2 positive trials, the intervention is then recommended. And the 4th reason not to recommend is that we believe there are too many side effects possible. So we had this update in 2023, again published in Anesthesia. Um, uh, we now work a little bit more in detail. You see the whole process explained there. And what are the studies we include, what are the studies we don't include. And in principle, we would only recruit studies that have basic analgesia given in the control group as well, but that's not always possible. And also, we would only accept studies which have been prospectively registered in a publicly accessible clinical trial database. We then think about the strength of the recommendation, and these are the factors which we take into account, and we grade the level of evidence and the strength of the recommendation. We also do a Cochrane collaboration risk of bias tool number 2 for the quality of reporting. And we, from now on, will no longer evaluate the studies on paracetamol and NSAIDs and COX-2 inhibitors because we know they work. And so these studies will no longer be evaluated because it's standard that we advise it unless there are contraindications to its use, of course. The primary outcomes is pain intensity reduction, at least 1 point, and then also a number of secondary outcome parameters. We then define the strength of the recommendation and the limitations of the study, and we will give the reasons for not recommending. So all the same as what I have said, we will a level of evidence assigned to it, and there will be a strength of recommendation. And you can read when we say strong, for instance. Let me now just apply this to what I know best, and that is post-op pain after cesarean section. And also, let me explain that although we have a recommendation, and you will see it in a moment, it is logical that you can still make your own choices to make it workable for you in your department. Post-cesarean section pain is serious. It is underestimated, but in this excellent and very well cited study by Gerbershagen et al. In anesthesiology in 2013 or 2014, they looked at 178 different surgical procedures and noted that in obstetrics, the highest pain scores were recorded, and that actually the cesarean section was the 9th most painful procedure out of all of the 179 surgical procedures. And the median pain score was 6. So, meaning that there is 50% of patients who have pain scores higher than 6, or 6 or more, and 50% 6 lower than 6, but still perhaps more than 4, more than 5. So in my book, acceptable pain scores. So we need awareness that there is a problem, and that's for all surgical interventions sometimes, and we need evidence-based protocols that are followed by everybody in the hospital, and there needs to be better follow-up of the patients to see whether their quality of pain relief is good. So open your eyes and go for a protocol, and I would recommend to you the Prospect protocol for C-section. We published this protocol for C-section in 2021. There was a small update in 2023, and there is now a full new update which will be published in 2026. We already had the first version in 2014, so it's already the 4th version of the recommendation. And this is the recommendation as it is accepted in anesthesia end of November, and I've just approved the proofs, so very soon it will be available online and then in published form. So this is a recommendation which took literature from the past, but added the literature from 2020 onwards to the end of 2025. So we ended up with 61 randomized controlled trials and 38 systematic reviews and meta-analyses. And there we had these recommendations, and I will go over them in a little bit of detail. So the first thing is we recommend basic analgesia. And not only do we recommend the use of paracetamol and NSAIDs, we also say that it should be given for at least 48 hours routinely and not on patient demand. So they should get it timely. We should also advise, because there is evidence that this works better, especially in cesarean section patients, if you give the paracetamol and the NSAIDs combined, because then you have better pain scores than we give them alternating with 2 or 3 hours difference. And pain scores are improved, opioid consumption is reduced if you do that. And in my institution, but you're free to do differently, we use 4 times 400 milligrams ibuprofen and 4 times 1000 milligrams of paracetamol, and we combine it so at fixed moments in time, and we give it orally as once it's possible, IV until oral administration is possible. Now, some might say, but pregnancy is a contraindication to NSAIDs. Well, postoperatively, it is not. There are some indications: preeclampsia, significant hemorrhage, renal impairment, thrombocytopenia, and NSAIDs activation leading to bronchospasm in asthmatics. However, these contraindications are very, very, very relative, and basically you can ignore them. Even in patients who had significant hemorrhage, even in patients with mild thrombocytopenia, even in patients with mild renal impairment, it is important to still give the NSAIDs, or you will see tremendous increases in pain. Let's now move to the second part of the system, and that's IV dexamethasone. In our 2021 guideline, we identified 4 studies with better pain scores and lower opioid consumption. In 2022, we had the use of, there was a publication in the European Journal on the analgesia efficacy of dexamethasone in post-cesarean section pain, a new meta-analysis which included 10 studies, again with better pain scores and lower opioid consumption. And then in the International Journal of Obstetric Anesthesia in 2025, there was this meta-analysis or review article published, including 16 studies. And then, so all of these things say prolonged analgesia, reduced rescue opioid consumption, reduced pain scores up to 24 hours, and less nausea and vomiting. And this was, now, to my surprise, there was a letter to the editor in the International Journal of Obstetric Anesthesia saying that neonatally dexamethasone might cause significant problems. I did not understand. There is somebody, not me, yeah. I did not understand why this letter was accepted, because the argument that it might affect neonatal condition is actually not so smartly thought out, because we give dexamethasone after birth of the baby when the cord is clamped, and even if the dexamethasone goes into the breast milk of the mother, the effect of that is virtually nihil. Why? Because one single dose of dexamethasone at birth is unmeasurable in mother milk, as also because the mother doesn't produce mother milk the first 48 hours, virtually nothing. And if that, even if there is a small and minute amount, this needs to go into the bowel of the baby. There needs to be resorption of the dexamethasone, first pass effect through the liver. So virtually there is nothing in these babies. And this will not result in hypoglycemia or hyperglycemia in the babies. So I think these arguments are a little bit strange. Okay, then we move to regional analgesia techniques. And the first regional anesthesia technique is the use of neurexual morphine. Most of the time intrathecal, but it could also be epidural morphine. This produces excellent analgesia. There is no doubt about that, but it comes with side effects. And the side effects include pruritus, nausea and vomiting, sedation, but most importantly, respiratory depression. And this chance of respiratory depression is extremely low, yeah? 1 in 1,000 or even less, but it is there. And therefore, SOAP and the American Society of Anesthesiology have produced these guidelines when you've given neuraxial morphine, what to do with respect to monitoring. And they say if you use a dose, which is the normal dose, something between 50 to 150 micrograms, you should check every 2 hours for the first 12 hours the respiratory rates, and then once every 2 hours from 12 to 24 hours. But can you imagine that in a normal pregnant patient who had a normal section, you go and wake her up every 2 hours to ask whether she breathes and whether she's not sedated? She would kill you, because finally, after hours of not so much sleep, she can finally sleep, and then a nurse comes to ask whether she's still alive. And if you have high-risk patients, you need to do the monitoring even in every hour for the first 12 hours as well. So it's even worse. And high-risk factors are listed on the slide here. So it is potentially safe, but it's certainly not patient-friendly. What if you are not using neuraxial long-acting opioids? Are there other local analgesia techniques which can be used, and are they as good as intrathecal morphine? And there have been various publications demonstrating the safety and efficacy of various blocks, like the ilioinguinal iliohypogastric block, like local anesthetic wound infiltration, like the abdominal wall block, stab block, quadratus lumborum block, and ESP block. And this is a very nice summary published in 2022, where they could demonstrate reduced pain scores with all of these blocks and improved and less opioid consumption as well. So, state of the art now, neuraxial morphine is effective, but these blocks are effective as well. However, adding wound infiltration to blocks, adding blocks to wound infiltration, adding wound infiltration or a block to morphine is completely useless. It's one or the other. They both work, they both are excellent, and all of the different types of blocks are excellent as well, and they are comparable to neuraxial long-acting morphine. So you choose based on your experience and how you want to work. But what is important is that everybody, also at night, also in the weekend, needs to be proficient in the technique you choose. And you can't say, now it's me, I can do an ESP block, so I'll do an ESP, but your colleague can't, so he will do wound infiltration, and then the third one does intrathecal morphine. This is bad. This is not a good protocol. Everybody needs to do the same thing in your institution, and 50% of C-sections are unexpected. Next aspect is the additional things, the surgical aspects. Like abdominal binders, like the type of incision, and they have been listed in our overview as well. So what do we do in my institution? Well, we are not using long-acting intrathecal morphine because of the nausea and vomiting and the respiratory depression. We are using, of course, basic analgesia always, and we are doing an ilioinguinal iliohypogastric nerve block and single-shot wound infiltration at the end of surgery. And I'll come to that in a moment, how we do it practically. We add just the ibuprofen and the paracetamol. We are giving dexamethasone 10 milligrams at birth of the baby, and the next morning 10 milligrams as well. But the second dose is not given in diabetic patients. We don't use Joel Coel incision because of it's not in the bikini line, so we're using a Pfannenstiel. We don't close the peritoneum, and we use the abdominal binders. Our rescue opioids are tramadol and oxycodone to manage a pain which is higher than 3. Why do we use this ilioinguinal iliohypogastric nerve block? Well, because it is indeed 24/7. It is simple and reliable. And it's not me or my colleagues that are doing it, although we introduced it. It's the gynecologist who does it at the end of surgery. It's quick, it takes 2 minutes. And there are no side effects of intrathecal morphine. You don't need to monitor respiratory depression. And we are using standardized formulation. We inject that and give that to the patients. And there is less side effects, as I mentioned, than with intrathecal morphine. So it's simple, it's easy, and everybody can do it. So what is it? Well, this is the standard anatomy of a cesarean section scar. So the first step is to inject in the fascia of the rectus muscle 20 milliliters of ropivacaine 0.375%, for instance, in the fascia of the rectus muscle. So 4 times 5 milliliters. The next one is to, in the corners of the wound, to inject 5 milliliters of subcutaneous local anesthetic. So that's already 30 cc's of 0.375% ropivacaine. And then finally you inject and you do a blind ilioinguinal nerve block at the crista superior, medial from it. And once that's done, the intervention is finished for us. So I just show you this film. So it will take about a minute. The surgeon injects 5 milliliters of local anesthetic in the fascia of the rectus muscle. It's important to do it in the fascia and not in anything else. And then he hands it over to his colleague, who does the other side. He could do it as well by just turning, of course. You saw him aspirate for blood, which is always a good thing. Then he injects the other 5 cc's into the fascia of the rectus muscle. And then they come to the next 2 steps. And the next step is a fan-shaped injection in the corner of the wound to block the iliohypogastric nerves endings that might not be blocked by the blind ilioinguinal nerve block. So 5 milliliters on that side and then 5 on the other, but in this film, the colleague will receive the needle and will do the ilioinguinal nerve block first. Well, he does it on his own side and then gives this to a colleague. Again, 5 cc's. He will then give it to the colleague who does an ilioinguinal nerve block, blind, next to the crista iliaca superior, medial. And once that's done with 5 cc's, he will end again doing the fascia. So it's not a subcutaneous injection of local anesthetic. Let us be clear about that. That is not what I mean by single-shot wound infiltration. It is a technique which is here described in this film. Okay, we're going to skip it then. This was Antwerp, where they do it in a hospital as well. This is Leuven. What do you notice? Leuven is cleaner than Antwerp. That's, of course, a small joke. We have the list of non-recommended interventions for C-section. The reasons are there. Some have limited procedure-specific evidence. So this is something you might consider for research because it's ineffectively studied. Or if it's a very difficult pain patient, you might add this to it because they most likely work, but the evidence is not strong enough yet. How is it done in Belgium? Well, relatively okay. They have standardized department protocols. They use routinely paracetamol and NSAIDs. They have rescue analgesia. So part of the protocols are well developed, but there is still a lot of work. Dexamethasone is only used in 1 in 4 institutions, and then even in still small doses. 10% only uses an anorexia long-acting opioids, and you would then think that 90% uses a local anesthetic technique. No, only about 24% uses an abdominal block or wound infiltration. 40% still are using epidurals. Oh my God, epidurals for a cesarean. She will not be out of bed. It works analgesia-wise, but it is not for enhanced recovery after cesarean. And then a number, meaning about 30%, are not using anything in these patients of regional analgesia techniques, which is horrendous. We started with the Prospect protocol in 2021 on the 1st of January, and we included all of our first 185 cesarean sections done between the 1st of January and the 30th of April. Everything, also the unplanned ones, also the ones in the weekend. And we looked at a satisfaction of these patients with the protocol and whether the protocol was followed. And we looked for it for 3 days. And that's an important message of today as well. Go and look to your patients and know whether it works or not. So, and we looked at it in the morning and in the afternoon for 3 days at rest, at movement, at coughing, at breastfeeding, at standing, and when they walked to the crib of their baby, approximately 2 meters. What we noticed was that in 55 patients out of 185, the protocol was not followed. And again, it was usually because NSAIDs were not given. 34 out of these 55 women in which the protocol was not followed were uncomfortable at one or more time points during their stay. In the 130 women in which the protocol was strictly followed, only 2 women had unsatisfactory analgesia sometimes. And you see the pain scores here. The pain scores are extremely low. We don't have pain scores of 5, 6, 7, and if we have it, it's 1 or 2. It's certainly not a median. It's a very low percentage, both at rest, at movement, at walking. Even at walking, you see that only 20% of patients, sometimes the VA is above 30, but that's not 60, that's 35 or 40 or 50. But so you see there is this, it does seem to work. It's in the afternoon of the first post-operative day that pain is the highest and that you might be extremely vigilant. No rescue analgesia. The median dose was 25 milligrams or 25 milligrams of tramadol given orally most of the time. But you can see the dose, the median dose is very, very low. And oxycodone is not used in our department. So we have the 4th revision of our guideline, and this is the one. It's up to you to implement whatever you think is viable. To end, I'm going to give you a few other examples, and then there is time for question. This is the appendicectomy guideline. We recommend 3-port laparoscopic surgery over open appendicectomy. We advise to give intraperitoneal local anesthetics, NSAIDs and paracetamol, of course, opioids for rescue, and that's for laparoscopic appendicectomy. For open appendicectomy, Tabloc or wound infiltration that are apparently the best options. And postoperatively, again, NSAIDs and paracetamol and opioid as a rescue. Same for laparoscopic cholecystectomy. We have these recommendations. And by the way, on our website, Prospect website, you find all these infographics so they can be very easy for you to use. This is the list of what is recommended in laparoscopic cholecystectomy. And we also have one for hip fracture patients. And again, go for it. The intervention which is recommended is the single-shot femoral nerve block or fascia iliaca compartment block, and then spinal or general anesthesia you can choose. So all of these things have been brought forward. Laparoscopic colorectal surgery These are the recommendations we make: surgical port site wound infiltration, rescue opioids, intravenous lidocaine, but we were not all 100% convinced. I'm convinced that intravenous lidocaine can work, but not everybody was. And of course, NSAIDs and paracetamol. And this was in the European Journal published as well. We have cleft palate. You see the list published in regional anesthesia and pain medicine. And you have a evaluation of the vaginal tears, management of pain after the vaginal tear, after the vaginal delivery. And you can see what has high relevance or what has not high relevance. Open thoracotomy, all of these things, but also an epidural and the other things, erector spinae block, rhomboid intercostal nerve blockade are only recommended if paravertebral block or epidural analgesia is not possible. Hallux valgus, new guidelines published in 2026. And you can see what is the advice here is same as the previous version almost. And you see that for an analgesic technique from anesthesia, it's an ankle block and local anesthetic wound infiltration. Thank you very much for your attention, and I'm happy to answer any question you might have.
Javed sir.
Hello. Yeah.
Yes, sir, we can hear you.
Yeah. Please. I'd like to have questions from the attendees, our fellows. Hello.
Anyone having question can unmute themselves and ask the question.
Sir, good evening. Can I ask a question?
Yes, please.
Sir, I have a question. You said you have to put a 5 cc syringe in front of anterior superior spine for the cesarean section. So, sir, how much centimeter do you mark just at the side of the crisis?
Sorry, so yes, for the ilioinguinal nerve block, you mean, eh?
Yes, sir.
So it's 2 to 3 centimeters deep. It's just a blind block. It's next to the crista iliaca superior, and you go with a small needle, 2 centimeters deep, and you just blindly inject 5 cc's. It's a field block.
Okay, sir. Thank you.
Thank you.
Yeah, there are two other questions in chat box also.
Yes, I see them. Yeah.
Yes, sir. So, what is the timing for intravenous lidocaine for abdominal surgery, sir?
Yeah, so if you use intravenous lidocaine for abdominal surgery, not cesareans, but for the procedures that we have described, you need to give it intra and postoperatively for several hours. So this means additional monitoring for these patients as long as this is running. So it's really something you could do in certain situations, but not for all. For instance, for day surgery, it's impossible to do. You need to at least give it several hours after the surgery as well, and not only during surgery. And the concentration of the drug, very good question. I probably didn't mention it. It's ropivacaine, 0.375% in total 40 mLs. So this means the total dose is 150 milligrams, which is below the maximum threshold.
Yes, sir. Sir, any evidence of QL blocks for abdominal surgery, sir?
For cesarean surgery, you mean?
A cesarean and other abdominal surgery as well, sir.
Yeah, it depends on the type of surgery. There are some where it works and others where it doesn't work. However, for cesarean section, it does work, but it is not a technique that you can offer 24/7 in most hospitals. I mean, half of the staff here in Leuven knows how to do it, but half of the staff doesn't. and they are also responsible during the night for cesareans. And so it has to be a technique that's feasible 24/7. And so if it's recommended, and you use it, you need to be able to use it 24/7. And for some procedures, that's not necessary. Elective abdominal surgery, you can only use the people that are there and that know it. But for surgery that is often emergent or unplanned, it's more difficult. So that's why we said we don't use TABlock and quadrilateral boron block and ESP blocks, although they work. But not only is it for that, but the other reason is it's more complex to do and it takes more time. So we lose a lot of time. I see some other questions in the chat.
Dr. Mark,
Yes.
Dr. Javed here. What
Yes.
is your take about this QL block for hip analgesia, post-operative hip replacement?
The QL block, or the which block?
QL block, QL. Quadriceps lumborum.
Yes. Well, again, we do not formally recommend it for total hip surgery. We say that it should be a fascia iliaca block or the other block in the groin. Anyway, we're not recommending the QL block because first of all, it's a more complex block to do. There is no evidence that it's much better than the fascia iliaca block, which is more simple to do, and the quadratus lumborum block has a higher chance of motor block. So that's why we are not using it, or we are not recommending it, as far as I remember. There is going to be an update soon on the total hip arthroplasty recommendation, but I don't think it has changed. What is the role of intrathecal morphine for cesarean section? Well, it is recommended. You can use it, but then you have to use the proper monitoring and you have to prevent nausea and vomiting. And you have to use the proper monitoring as well, meaning 12 hours at least. Every 2 hours you have to wake up the patient. And in the morbidly obese patient, you need to do it for every hour for 12 to 24 hours.
Okay. Thank you. More questions, please.
Well, there is another one in the chat. Other dexamethasone, do we have other steroids which we can use? Well, glucocorticosteroids can be used in the appropriate doses. But this means that if you use these glucocorticoids, you need to do 125 to 250, sometimes 500 milligrams to have an equivalent dose as the 10 milligrams of dexamethasone. But they are effective as well. Yes, indeed. And then are there any pediatric guidelines in place? Well, we have a tonsillectomy guideline that's in place, and that's also for children. And then appendectomy is also for kids. So some of these procedures, if you do them in kids, are exactly the same as in adults. Yeah, the recommendation for pain relief, I mean.
This is Anshuman. Hi, Mark. I had one query. I wanted to know intrathecal morphine is suggested as equivalent equipotent in the duration to that of TAP. Do you think so?
To the blocks, you mean? To the equivalent in duration? Well,
in the duration.
Yeah, there might be a small difference. Intrathecal morphine might be a little bit longer, but from the studies we've seen, the effect of intrathecal morphine in the correct doses is more or less the same than the abdominal wall blocks and the wound infiltration. Intrathecal morphine might work a couple of hours longer, but not that much. Yeah.
And another one question I had, what do you suggest for awake clavicle surgeries? Because we get a lot of clavicle surgeries. Do you have anything for that?
I'm not a specialist in that. So you're meaning now to give anesthesia for awake clavicular surgery. I'm not an expert in that, but I believe Steve Coppens is going to give a talk on that, and he's an expert. And I think he's using a infraclavicular nerve block for that. But I'm not sure what he's using at the moment. So I have to not give my opinion on this because I don't think it's relevant.
No problem. Point taken. Thank you.
So, and then do your prospect guidelines include pediatric RCTs? Yes, if they are available for certain surgeries. The other question, can we use fentanyl instead of intrathecal morphine? The answer there is no. Fentanyl is a short-acting lipophilic opioid which only lasts for 2-3 hours. It's for intraoperative analgesia and anesthesia. It's not for postoperative pain management. And then there is a question on the role of magnesium sulfate in laparoscopic surgery. There is, I think it has a value in certain surgical procedures, but the evidence is insufficient to support it at the moment. So we need more trials to be able to say it will work or not. I don't know if there are any other questions.
Javed sir, can I come in?
Of course.
Yeah. Mark sir, excellent talk and very useful insights. I just wanted to ask regarding the transversalis fascia plane block, because we have used it. We had done a RCT also, and we have been using it for cesarean section, sir. Cesarean section.
And which block, sir, please?
Transversalis fascia plane block, sir. TFP.
Yes, at the moment, also the evidence is not strong enough to support it. Or yes, there is just enough evidence, but the problem is the same. All of these blocks work. All of these blocks have a positive effect, but the issue is, and you can use them. You can use them if you want, but there are two problems. Does everybody in your institution can do it? Because you can't say, if I'm here on call, I do it. But the next day, it's another person and he does something completely different. That annoys the nurses, the patients, the gynecologist, and makes it all more complex. And then the second thing is, it will take a little bit more time than the technique I described with wound infiltration and the blind the blind ilioinguinal nerve block. It is more time consuming. And if you're in a busy practice, it's not always possible to do that.
Yes, sir. Thank you.
Thank you. There is a question on recommendation for robotic general surgery. We, at the moment, we haven't made a differentiation between robotic surgery and laparoscopic surgery. So anything we recommend is also there for robotic surgery. There is just not enough evidence where they only look at robotic surgery. One oral is the same as IV for paracetamol. Basic analgesia usually is started, it can be started pre-operatively prior to incision in most procedures, with one exception, and that is the cesarean section patient where the baby needs to be out first. I don't know if there are any other questions. Sorry, I haven't understood the question.
Dr. Rakesh, sir, please, can you please unmute yourself and ask the question? Dr. Rakesh? Sangamitra?
No, sir, no response from Rakesh, sir.
Okay, so can we conclude the session, Javed, sir? Javed
Hello.
sir?
Yeah, tell please.
Yes, sir.
We,
So,
we can conclude the session.
yeah. Sir, please conclude.
Thank you, Dr. Mark. Thank you so much.
Thank you very much for your attention and for listening to me. Thank you very much.
Thank you, Mark sir. We all hope to see you in our Aura conference
It will be my pleasure to
this
come.
year. And then we can have a direct one-to-one talk and discuss a lot more about. Yes, sir. Hope to see you, sir. Thank you for joining us, sir, today.
Thank you very much, and see you next time. Thank you very much. Bye-bye.
Thank you. Thank you. Bye. So, moving ahead with today's session, for the PBLD session, which will is my screen visible?
Yes, ma'am.
Is my screen visible?
Yes, ma'am. It is
It's visible.
Yeah. So, I welcome Dr. Amrita ma'am. Amrita is a dear friend of ours and one of a very active member of EURA. So for fellows, Amrita ma'am is always there. I welcome Dr. Amrita Rath ma'am. She is a anesthetist. Her area of interest includes regional pediatric neonatal anesthesia. She is a EDRA from UK, fellow from College of Anesthesiologist Ireland, European Diplomat of Anesthesia and Critical Care UK. She is a gold medalist in postgraduate exam, BH anesthesia, pediatric, regional anesthesia, focus in pediatrics, and we also. So I welcome dear Dr. Amrita. Please carry the session from here.
Thank you so much, Dr. Sangamitra. Can you give me the sharing rights?
Yeah, Rohini, can you do it, please?
Yes, just a second.
Hello,
So
everyone.
we have selected 3 fellows, ma'am, but still I feel ki we will give some, liberty to them and we will ask some questions to the rest of the fellows.
Ma'am, you
It's a
can share your
request to the
screen.
fellows that it's not an exam for you. We just want to orient you technically and share your knowledge with us. We all know you are a consultants and super excited for the session. So, Amrita ma'am will start the session.
Yeah, thank you, Dr. Sangamitra. Yeah, mine will be clear. Actually, maybe she is facing some network issues, so I think I will be fine. Am I audible?
Yes, ma'am. Yours is
Yeah,
clear.
thank you. Thank you so much. So before we move to the next brainstorming, I offer you a good black coffee so you'll have a good time. It's nothing if you can answer or not. It's ultimately the purpose is to learn something together. So let's start the problem-based learning session. So I was introduced. So in the next couple of minutes, we'll discuss few topics, 3 questions, and the kind of must know or maybe something which we have not covered yet. So may I request Dr. Akanksha to unmute yourself and take up the challenge?
Good evening, ma'am. Myself, Dr. Kanksha.
Hi, Dr. Akanksha. So next, I will be displaying one image to you, and you
Okay,
have to
ma'am.
find what is the mistake in that image. Are you
Okay,
ready?
ma'am. Yes, ma'am.
Okay. So my co-fellow was performing a ultrasound guided subclavian perivascular nerve block. So can you identify if it's a correct image or it's a wrong image?
Ma'am, I'm seeing only sir's photo, or are you showing me the image? I'm sorry,
It's
I'm
the
not.
entire image. It's the entire image. It is your OT setup. The patient already has been given G and is performing a subclavian perivascular nerve block for post-op analgesia.
Okay, ma'am.
Yes.
Uh,
Rest of the candidates you can just write in the chat box if you find something the answer.
Ma'am, I just feel the ergonomic is not correct, as the sir is standing and the monitor is not clearly visualizing to him properly, which he should be in front of him so that he can visualize and give the block properly.
That's a perfect answer. So in better language, we can say along the site, like the
Yes, ma'am.
operator, rather than calling it a sir, we can say operator, patient, and ultrasound machine should be in one line.
Yes, ma'am.
So it is not the correct approach.
Yes,
Okay.
ma'am.
Are you happy with this?
Yes, ma'am. I'm happy since
It's
it's in the
ergonomic
same line of her eyesight.
along the line of sight.
Yes, ma'am.
That is, yes. Or you can say
But ma'am,
along the visual
monitors.
axis.
I think I didn't see the monitors. The up.
No, it is there. It is there. Let's focus on
Okay.
our procedure. Yeah. So you can shortly call as ALVA, that is along the line of visual axis. So that is a
Elva.
better terminology.
Yes, ma'am. Yeah,
Okay.
ma'am. Yeah.
So can you tell me what are the steps for performing a successful ultrasound USG RA? Be quick.
Ma'am, I think I was told to do PNS, but I'll try.
Okay. No issues. Dr. Divya, can you pitch in? Yeah.
Yes, ma'am. For successful performing USG guided regional block, we have to have a good USG machine, and it should be functional, and we should be able to switch on the machine, and we should be knowing our nobology and probes properly, and then we should be knowing the probe movement, how to move the probe, and which movement have what the effect, and what will be the correct probe for that block. And the machine should be in the line of vision, and we should be able to visualize our needle properly while we place the probe and while we are giving the drug or doing the block.
Okay. Are you done?
Ma'am, there are many points. Should I cover all?
So can you tell me basic thing like have you heard about slim rack?
No, ma'am.
Okay. So slim rag is a basic no it's an acronym that stands S for the septic precautions, L stands for the light source, I stands for an IV line, M stands for the required ASA standard monitors. Okay. R stands for the resuscitation device, A stands for a trained assistant, and G stands as a backup to GA. Okay, so whenever you answer, first you have to say, I will get over the slim rank. It is a standardized mnemonic which is widely accepted. And after that, another thing is always you have to check the site of the block. That is stop before you block. Right?
Yes.
So these are the important things which you have to answer before you go ahead. I can see some enthusiastic people who have correctly added to more to it. So if you are, you can go through, this is our AORA pre-procedural checklist. Okay, so you should go for the patient check, the procedural check, the document check, the equipment check, the pre-block check, and special consideration if at all. It is freely available online. You can go through the AORA site, website, and you can go for this checklist. In the same, they have also mentioned few points which I told in brief. It is elaborately given in this site. So you can always go for the, again, you miss the consent, which is very, very important. Okay. Then,
Yes.
yeah. So ergonomics, you guys have already mentioned. Presets, you had already mentioned. Probe selection, going for the sterility technique. So this is all I have already explained you in brief, right?
Yes.
Yeah. So this is the important things which you should know before performing a ultrasound guided regional nerve block. Right? Thank you
Yes,
so
ma'am.
much, Dr. Divya. Again, back to Dr. Akanksha.
Yes, ma'am.
Okay, are you happy for the next question? It will be in your domain as the preset.
Yes, ma'am.
Okay, so we are performing certain block. So you have to identify the block being performed.
Yes, ma'am. Ma'am, should I answer?
Yes, you can
Ma'am,
proceed.
it's a obturator nerve block.
Okay, what is the clinical indication for performing a obturator nerve block?
Ma'am, usually while you do procedures like TURP or bladder surgeries where the nerve
TURP or bladder surgery or both?
Ma'am, a bladder surgery.
Okay, why it is important in a bladder surgery?
Ma'am, because the nerve, whenever the, what I say, ma'am, whenever they touch the wall of the bladder,
Any
there is a,
particular wall?
sorry, ma'am?
Any particular wall or the entire wall of the bladder you mean? Lateral wall.
Lateral wall, yes, ma'am.
Okay, so what happens if you're given a spinal, isn't it that the obturator nerve is blocked?
No, ma'am, that the nerve doesn't get blocked with the spinal.
Okay, so it does get blocked because when you are performing any other surgery, say amputation of the medial side, like amputation of above knee, so that is
Yes,
also
ma'am.
the involvement of obturator nerve, right? But
Yes,
we
ma'am.
don't block it separately. But why we have to block it here? Because there is a concept of local muscle arc. Like when we directly stimulate the nerve get activated. Once it gets stimulated. So that is
Okay.
why we consider blocking it because in the lateral wall it gets directly stimulated. So a local arc is also can be performed.
Okay, ma'am.
Okay,
Yeah.
fine.
Yeah.
So
Thank
can
you,
you
ma'am.
tell me any step-by-step approach? How do you perform a PNS guided obturator nerve block? I know it is a beyond this class, but if you are happy, we can take up, or else we'll run it up.
Ma'am, just with your guidance and help, I'll try.
Okay.
Ma'am, first of all, I'll check all the patient's parameters. I will apply all the
Fine,
monitors.
let's everything is okay. We have
Okay.
already discussed. We'll jump to the technique.
Okay, ma'am, so we will have a PNS monitor on with the needle and the electrode placed as it is shown in the picture. So we'll place it 20 centimeter away from the site where is to be blocked. So the electrode is placed on the thigh and the needle, we use 100 centimeter needle for that, insulated needle. And then a tubing is connected with the needle.
So
And
that is done. Where is your
okay.
insertion point and direction of the needle?
Yeah, and ma'am, then we'll place the patient in supine with the side to be blocked. The leg has to be abducted. And then we will place, ma'am, so with the inguinal canal, 2 centimeter below and 2 centimeter lateral to the point, we will inject, we'll put the needle inside just towards the lateral and we'll see the contraction of the obturator muscle over with the nerve. We'll see the contraction of the muscle, medial muscle.
Adductor muscles.
Yes.
So that is one way, that is a distal. What I do mostly is I palpate the pubic tubercle, 1
Yes.
centimeter lateral and 1 centimeter caudate.
Okay.
You insert your needle towards the same side knee. So you will get the desired. Okay, what is
Yes.
the desired PNS I'm happy with?
Ma'am, by mostly at 0.5 milliampere or less than, the contraction should go away when we give the local injection over there.
Okay, first we'll give the local injection, then only we confirm. Is it like what I once understood?
No, ma'am, we will first see where the contractions are happening. Say, we'll place with 1 ampere, slowly decreasing, coming up to 0.5. And we'll see when below 0.5 is still the contraction is present or not. And then we can give the local.
Okay, so I got the contraction at 0.2. Can I inject the local anesthetic?
No, ma'am. It's inside the epineuron of the nerve, obturator nerve.
It's
So,
intraneural.
yes.
Okay. Fine. So can you tell me what is a chronaxy? What is a Rio base? What is a chronaxy?
Okay, ma'am. So Rio base is the minimal current which is required to generate action potential for the nerve to get depolarized. And Chronex is the minimal time duration required twice the Rio base to generate the action potential.
Okay. So why don't you feel pain when you stimulate the peripheral nerve?
Ma'am, as you know, Chronex is the minimal time or say milliseconds or required. So we send a pulse width of 0.1 millisecond. And with the 0.1 millisecond and the chronaxy of motor nerve fiber is less, that is around 0.15, so it speeds quickly. So the depolarization happens quickly. So the motor nerve fiber gets stimulated first and the sensory fibers are not stimulated. So it's a less painful for the patients.
Right. So the large myelinated fibers get stimulated at lower threshold. So that
Yes.
is why the patient will feel the touch or the motor response, but not the pain. Have you heard the term called as sense?
Sense? No, ma'am.
Okay, so it's a homework for you. You
Okay.
have to read what is a sense.
Okay, ma'am.
Okay, it's
Yes,
a
ma'am.
sequential electrical nerve stimulation in which 3 stimulation are given, 2 shorts and 1 large. And
Okay.
if it's a large stimulation is having a twitch, that means your needle direction is correct. And with the short, if it is like you are getting the stimulation, means you are near to the nerve. So when all the 3 stimulation are correct, that means you are in the correct place.
Ma'am, can I ask you?
Yeah, sure.
Ma'am, so you said there are 3 stimulus. So
Yes.
this has to be.
So can you see the image here?
Yes,
So
ma'am.
you see 2 stimulation of SEM and other will be a bit prolonged. It's the longer one. It is away from the needle from the nerve will be at a distance. So if at a longer pulse, longer duration you are getting a stimulation, that means your direction of the needle is right. Like if I talk loud, okay?
Okay.
I talk loud, even if I'm at a distance, I can hear.
Hmm.
If I can hear a whisper, means I'm no close to it. The same analogy goes here. If your nerve is getting stimulation even at a distance, that means the direction is right.
Okay.
If you are getting near to it, means you are at the correct place. That is at the 0.3 to 0.5.
Okay, ma'am.
So you have to check on all the 3. So you have to read in a bit more depth. I just gave you a crux of it.
Yes, ma'am. Sure, I will do.
Yes.
Yeah.
So can you tell me what are the color boxes indicate here? What is yellow? What is red? What is blue? And what is yellow?
Okay. Ma'am, so the yellow box which is showing 0.20 is the milliampere. It's showing the current voltage. Means we can increase or decrease with the knob, which is a round circular knob below. 0.10 millisecond is the pulse width. 2 hertz is the frequency, and 1 kilo ohm is the impedance or the resistance, which is with the skin tissue and connective tissue.
Okay, so you are right. You mentioned all the points correctly. So we'll move to next question. So what are the type of needles or catheters you know, and what are the benefits or the demerits of each of them?
Ma'am, it's a insulated and non-insulated types too. So the insulated ones are the needle where the shaft of the needle is insulated and the tip is left over. And non-insulated one is still on tip and the shaft which is non-insulated. Means there is no sheath over there.
Which is good.
Sorry, ma'am?
Which is the better one?
Ma'am, insulated one.
Why?
So ma'am, the insulated one, when the needle generates a current, so it is at the tip where it is there. So it doesn't dissipate so much of.
Very good. So have you heard about needle over the catheters and catheters over the needle?
Ma'am, I have heard but never read or seen, so I'm sorry, might not be able
This
to.
is again a homework for you.
Yes,
so which
ma'am.
is better, needle over the catheter or catheter over the needle? So
Okay.
catheter over the needle are better one. So if you see the diagram, if needle is a wide bore and catheter is a narrow bore, so the
Okay.
drug spillage will happen because you have a wider thing and you're inserting a needle, a catheter. But if
Okay.
the needle is narrow and catheter is big, the chance of drug leak will be less.
Okay.
Okay. In
Yes,
details, you have to live. This is a crux just to give an idea what else you can study.
Yes, ma'am. Sure, ma'am.
And we are lacking time, so I cannot explain you more. So anyways, thanks a lot, Dr. Akanksha, for
Thank you, ma'am.
having a good time. Okay, Dr. Devpali, may I ask you to unmute yourself?
Hello, ma'am. Good evening.
Hi, how are you?
I'm good. How are you?
Are you ready?
Yes, ma'am.
Okay, fine. So this is I'm going to explain you on I'm going to display one cadaveric image, and this is a very
Okay, ma'am.
important image. You have to tell me what does this image depict.
Do I need to tell you all the structures that are visible here?
No. You just tell me what is the important information this image is trying to depict.
Ma'am, actually, the image on the cadaver is showing the phrenic nerve on the interior surface of the anterior scalene muscles, and the trunks, the superior middle and the inferior trunk, which are emerging out in between the anterior and the middle scalene muscles. And on the right side of the screen, I can see
Dr. Dipali, can you tell me, as I descend from C5 to C8, Dr. Sanjay, can you please mute yourself? Dr. Sanjay, can you please mute? Yes. So can you tell me what is the relation from C6 to, as we go down from C5 down, what is the relation of the phrenic nerve?
As per literature, when we go 1 centimeter down, the phrenic nerve stays away from the brachial plexus. Almost 3 mm diverges from the brachial plexus.
Perfect.
So the more we go down, the better will be the chances of sparing the phrenic nerve in the block.
That's perfect. So better I can just try to restructure your answer. So as we move 1 centimeter down from C5, the phrenic nerve moves anteriorly or medially?
It moves medially.
Anteriorly or medially?
Anterior and medial. And medially.
Medially.
The brachial plexus goes laterally, and the phrenic nerve moves anterior.
So better is actually phrenic nerve moves, not the brachial plexus. So phrenic nerve moves anteriorly.
Yes, ma'am.
Yeah. Okay. So next questions for you. Can you tell me the course of phrenic nerve? I know you must not have read this.
Ma'am, actually the phrenic nerve, it comes from C3, C4 and C5. And after once it emerges, it lies on the anterior surface of the anterior scalene muscle, and then it lies both right and left. They are different relation to the subclavian artery. The right one is medial, I think, to the subclavian artery, and then it enters the thorax through the thoracic aperture and goes along. And the left phrenic nerve, it goes lateral to the subclavian artery.
Good. So how do you minimize the risk of phrenic involvement during an interscalene approach to brachial plexus?
During the interscalene approach, they're using the lesser volume, but the lesser volume, as per the studies, they say 4.8 ml of the lesser volume, but I don't think that much less amount of drug will give me complete anesthesia and analgesia for the particular surgery.
How much drug?
10 to 12 ml, I think will do. 10 to 12 minimal ml. And as far as by looking the needling, while needling the during the USG, we should stay away from the phrenic nerve. If we are able to visualize it, we should stay away from it.
Can you restructure like that? The needle should be visible all through the procedure.
Yes, ma'am. Needle should be visible throughout the procedure. So we should. Yes, ma'am.
So if you are talking may I just ask you a question? If you're saying I don't want to go near to the phrenic nerve, so where do you want to inject? Any particular, can you tell me exactly the particular area where you would like to restrict yourself?
Actually, I couldn't listen to your question. Some background noise was there.
Okay.
Can you please repeat
it? I'm asking, you mentioned that I should not go near to the phrenic nerve, right?
Yes, ma'am.
So my question is, if you don't want to go near to the phrenic nerve, then where you should restrict yourself?
Ma'am, because whenever there is involvement of phrenic nerve, almost 25 to 30% of the...
Dr. Dipali, you didn't get me question. My question is very simple. You told me I don't wish to go near to the phrenic nerve. That is the correct answer. So my next question is, if you don't wish to go to the phrenic nerve, then till when you will restrict yourself? Your needle will be restricted to which place? Or in otherwise, where should I deposit my drug?
Where should you deposit your drug?
Yes.
Ma'am, C5, C6, at the level where I can see the C5 and the C6 ke upper and lower.
So this is C5, this is C6, okay?
Yes.
This is my middle scalene.
Yes.
So anterior scalene, this is my middle scalene, okay?
Okay.
So the point of injection I will just number it. You have to tell me which is the correct one. This is 1, this is 2, this is 3. Where should I put my needle?
Ma'am, nowhere near 3. And it should be at the 2. मतलब जो periplexus injection है, जहाँ पर adipose tissue है, there we will give the injection.
So it is at 2.
At 2, yes, ma'am.
So what I was asking, phrenic will be somewhere here. So if I don't wish to go to the phrenic nerve, my needle should be restricted posterior to the traffic light sign or
yes,
the
yes, ma'am.
plexus.
Yes, ma'am.
Okay, never cross the midline to the anterior part. So this is what I wanted you to ask. Okay, fine. So so this is the course of phrenic nerve. You might be asked in your exam. Okay, and the course of left and right correspondingly. How to minimize the risk? You have already mentioned about the volume and going for a periplexus or extrafacial. Okay, what are the phrenic sparing options you can offer to the patient?
Ma'am, it depends upon the surgery. If we are going for the shoulder surgeries, definitely we'll have to go near the trunks only. So I'll go for the scut block, which involves the superficial cervical plexus and the upper trunk. But I am not experienced in that because many times during scanning, I am not able to see it. Apart from it, when I'll go infraclavicular, at that point, there are less chances of blockade of phrenic nerve. The infraclavicular approach.
So can I perform a lateral infraclav for a shoulder surgery?
Ma'am, along with that, I will have to give a separate suprascapular nerve block with it. Otherwise, the shoulder surgery I won't be able to get it done alone in the infraclavicular block.
Okay. So I will just try to refine your answer. So what happens in lateral infraclav? The main supply of shoulder is suprascapular.
Suprascapular, lower subscapular, axillary, and the pectoral nerves.
Yes. So major is from suprascapular and axillary.
Yes.
Okay. At the level of infraclav, there are chances axillary also would have taken off his branches.
Yes, so I'll have to give separate axillary nerve block also on the back of the
If you
humerus.
have to do a suprascapular, you have to do a axillary, you have to do a infraclav. Don't you think the volume will also exceed?
Yeah, it will exceed.
So better is the last point where you can consider for your shoulder is up to costoclav.
Now, costoclavicular is a good option for this shoulder surgery. But ma'am, in the articles I have read, they have said that there are chances of involvement of suprascapular nerve in that. But
I agreed. I understand that. And why I agree to what you told, and I also have been. So there is a misconception, there is a controversy that if you are giving a costoclav, there are incidents in which suprascapular is missed out. So even in costoclav, you have to give an additional
suprascapular nerve block.
That is agreed. But lateral infraclav, again, you have to give 2 injections. Again, you have to give axillary also separately. So last point is costoclav as per the literature. There is something called as the chimney effect. So
which effect?
Chimney
effect.
So what does chimney effect say is that all the plexus, the brachial plexus are inside a common sheath. Okay, it is something like a birbal ka khichdi. So you give the heat from down and you expect it is going up. So if you tilt the costoclav, it is enclosed in a single sheath. So you are giving the costoclav and you are expecting the drug will go up to the interscalene if you give almost 35 mils. The same sheath, if you go a bit up, is your subclavian perivascular. That is also one phrenic sparing option.
Almost 60% chances of involvement of phrenic nerve there.
So here I would ask you to redefine your answer in a way. I will give anesthesia option and analgesia option. Anesthesia option, costoclav or your subclavian perivascular or scud block. Analgesia option, you can talk about the shoulder block. Shoulder block is an injection of the axillary nerve block and the
suprascapular nerve block.
So that is the complete answer. Okay, so what are the approaches to the upper trunk block?
Upper trunk, do I need to tell the whole sequence of blocking this upper trunk?
No. Have you heard about proximal upper trunk and a distal upper trunk?
No, ma'am, that I don't know. I just know how to scan from the subclavian area and visualize the roots from where they are emerging. And
Okay, there are actually few literatures who says when the C5 and C6 merge, if you perform at the level of that, it is called as the proximal upper trunk block.
okay.
And if you go a bit distally, where there is the SPA arrangement, like from anterior to posterior, suprascapular, posterior division, anterior division.
The anterior
And
division.
you are giving the drug between the suprascapular, posterior division, and maybe posterior and anterior. That is called as the distal trunk block. Basically, you are going even more distal, so the phrenic is going even more away. No, it's by 1 mm, but as we read, 1 centimeter is also like away from the phrenic by 3 mm. And so it is just a building concept. It is not very, two people have only described this proximal upper trunk and distal upper trunk. Any question from your side?
Ma'am, one thing I would like to ask, if we have got a patient who is not a fit candidate for general anesthesia, and we want to get the shoulder arthroplasty or shoulder arthroscopy done of that patient, so then how would you approach the patient for giving the anesthesia? Which block will you prefer?
I will go for a cervical plexus, superficial cervical and upper trunk block, and will minimize the volume. Just give that much of the drug, which is enough to bathe the upper trunk.
And how much drug will you take in this
I
upper
have gone
trunk?
as low as 5 to 7 mils.
5 to 7 ml in upper trunk and almost 2 ml in superficial cervical?
Super cervical, you give 0.2%. So volume is sensory, 5 mils is sufficient. Here you give the anesthesia block, 0.5% of propionate.
Okay.
Or 0.75, whatever you want.
Okay.
Fine.
Thank you.
Yeah, thank you all. I think it was an engaging session, at least from my side. So, and we tried to cover 3 questions as promised to Dr. Sanghamitra in this, not in the stipulated time, maybe some 3 minutes extra. So, any question if you have anything related to here, you can ask in our WhatsApp. I will be happy to answer, or maybe any other mentor who is there in that group. Over to you, Dr. Sanghamitra.
Thank you, Amrita ma'am, for conducting the session. And I'm especially thankful to these 3 girls who has volunteered to be part of PBLD, because it was just a month or so that they have started the fellowship, and they have happily volunteered to do this session. So I'm really thankful to these 3 girls. And of course, I'm thankful to Amrita ma'am to, tailor the class according to their suitability. And the session went very well. I think we have encouraged them enough today. So thank you, Amrita ma'am. Now
Thank
we
you
will,
so much.
we will move now to our Gaurav sir for the quiz. Gaurav sir has already started sharing the screen. So the quiz is open for everyone. Let's see who wins the quiz today. Over to you, Gaurav sir.
Yeah, hi. Just 10 questions, simple ones. You've already covered everything today in the class and maybe a few in past few classes. It will be a game of fastest finger first. Whoever answers fast will be winning. And I hope you know how this works. You have to log in using this code or this scanner, and you need a separate device to answer.
Do we need to download this app, or we can scan
You can
the
go
code
directly to the website. You can directly go to the website.
You just use your scanner on your phone, and even that will do. You don't need. Do we need to download, sir? No, na.
No. You don't need to download. You just need the scan the QR code is visible in your screen.
Sir, QR is not visible.
Not
Just
visible.
give me 1 minute. Is it visible now?
No, sir.
No, sir.
It has
Was
stopped
you
sharing.
wish me to share? Dr. Gaurav, do you wish me to share?
I'm trying once again. Just give me 1 second. Is it visible now?
Yet, sir. It is showing that you have started screen sharing.
But the QR code isn't visible. Yeah, now we
it's
can see
visible
it.
now.
So you need a separate device because your questions will be visible on the screen that you're attending right now. You need a separate device to log into kahoot.it. If you don't have the app, just log into kahoot.it or just scan this QR code.
Please avoid using pet names. We get confused later on who is Rocky and PP.
Yeah, you can edit your name to your first name. So on the device that you have logged in, you will get the answer options. There'll be 4 options, color coded also. And you will get the questions on this screen that you're visualizing right now. Is everyone okay to start? We have 17 people joined till now. So I have a sore throat. If my voice breaks in between, I'm really sorry about it. Uh,
I think we are good to go, sir. No one else is joining, I guess.
Ma'am, is the whole screen visible or there is a black box visible there?
In between the black box is coming, sir. A small black box at the end of the screen.
I think it's gone now.
It has shifted up and now gone.
Okay. So there are 19 people. Should we start?
Yes, sir, please.
So there comes your 5th Feb quiz. That's the first question. The corner pocket in supraclavicular block refers to LA deposition between pleura, first strip, between upper and middle trunk, posterior to subclavian artery, inframedial to subclavian artery. So you have to be fast because these are simple questions. The timing is less. You just have to go quick as fast as possible. So most of you could answer it rightly. Getting the scoreboard for the first answer, Kalpana is leading, Surabhi is second, Rocky is third. Others, you have time to buck up. Compared to long bevel needles, short bevel needles reduce tactile feedback, increase nerve penetration associated with less intraneural injury, produces stronger motor response. Great. Let's see the scoreboard. Kalpana is still leading. Surbi and Rocky second and third position. Napika and Sai have jumped a few levels. Echogenicity of nerve in short axis view is best described as honeycomb, hypoechoic, anechoic, hyperechoic. Great. Oh, short axis view, okay, might be confusing, but the best answer is honeycomb. So let's see. Again, Kalpana is on fire with 3 correct answers in a row. Akash and Dipali are now second and third position with a great rise. So let's see what happens with the next one. Increasing ultrasound frequency results in great. So most of you got right. Increased frequency increases resolution, improves resolution. Okay. Kalpana is still on top. Sai is second. and Kalpana has a streak of 4. You guys have to buck up. I'm sure you'll be able to, because there are double point questions also, which will come up. Using combined USG and PNS technique, the most reliable confirmation of correct needle placement is. Wow. So half of you got right. I'm doubt why so many of you got it wrong. So basically, combined technique, the most reliable confirmation is the local anesthetic spread around the nerve that you see. The elicited motor response is for safety. Okay, Rocky got, I think got this right, and Preeti has jumped 6 places. Akash is second and Mehak is third. So Kalpana, you still have time to make it up. So it is a multi-select question. There are more than one answers, and it's a double point question. So hemidiaphragmatic palsy is seen in. So those who have answered the correct ones will get the points. Let's see what happens to the scoreboard. Rocky is still leading. Sai has jumped the third position. Surbi in the fifth. So which drug class is consistently recommended by prospect unless contraindicated? That was a simple one. Yes, so all of you got it right. Alpha 2, I'm sorry, whoever answered it must have just been fast. So Rocky is still leading. Kalpana is back on the board. Akash and Sai second and third position. This is the eighth question. Comet tail artifact seen during RA is most commonly due to. Yeah, it's due to reverberation artifact. And half of you got it right. Why acoustic shadowing? Comet tail is not acoustic shadowing. Acoustic shadowing is seen in bones. Rocky is leading. Akash and Sai second and third position. Kalpana is still on the board. Kalpana, you can reclaim your position with this question because it is a double point question. Primary goal of prospect guideline is to. So all of you finished it before time. So it is to minimize opioid use. It was recently talked about. I don't know why. Other options. So Kalpana is back on board. Rocky is leading. Rashmi is third position. So that is your last one. Again, a double point. Motor response at 0.2 milliamperes during PNS guided block mostly suggests what? So being a simple question, the fastest one will claim the leaderboard. So at third position is Akash. At second position is Kalpana. And the top is Rocky. Mehak and Sharda are the runners up.
So Rocky is, I believe, Rakesh sir. I don't know. I'm not sure.
Yes, sir. Yes,
May
ma'am. Ma'am, I
I
got
thought
the
so.
last question wrong, which was very easier one.
Okay. Good. Anyways, thank you, Gaurav sir. Thank you for chipping in
Thank you,
today
ma'am.
and
Thank you
for this.
for this opportunity. Thank you so much.
Thank you, sir. And I think there are no questions from fellow side because the session is over and discussion is over. So we can call it a day today, Gaurav sir.
Thank you, everyone. Great job, guys. Good night.
Good night, sir. Thank you. Thank you.